Axonics can actually help with retention as well. The way the modulation works, it creates, not only can it control overactivity, it can also help underactivity as well. And we may get to that briefly. And also fecal incontinence is basically the involuntary loss of stool. So how does the bladder normally work? We all know this, our bladder fills up during the day based on what we put in it. And nerve signals are sent to our brain from the bladder, letting us know it's time to go to the bathroom. And then we urinate by other nerve signals, controlling the bladder to contract the bladder and then to relax the sphincter muscle so the urine can exit. And that's it in a nutshell. So these are some of the terms that we might see when we see you in the office, talk about frequency. I think anyone that goes more than 8 times a day during the waking hours or more than every 2 hours, that's probably what I would call urinary frequency. I think we all know what urgency is, this uncontrolled feeling that you better get to the bathroom in a hurry. Incontinence means loss of urine, in this case, urgency. Nocturia simply means getting up more than 2 times a night, which can be multifactorial, but nocturia is also one of these things that can often be due to overactive bladder as well. Fecal incontinence, and although we're going to talk mainly about urinary incontinence, fecal incontinence is important because the technology we're going to discuss is actually just as successful in treating fecal incontinence as it is treating urinary incontinence. And it may be not something that you talk about. It may be that you have both urgency, leakage of urine, and fecal incontinence. But urgency is this sudden urge to pass stool. And unfortunately, the urgency fecal incontinence is all of a sudden you can't stop it from coming. Some patients also have passive stool, where all of a sudden the stool just leaks out without any awareness. How do these things control our lives? There's been a lot of studies, and it's shown that people who have severe incontinence, either of urine or stool, actually have a similar psychological profile to patients with depression. And obviously there's degrees of how this affects people's lives. Some it's more of a nuisance, but some it can be very debilitating. It can limit them participating in athletics, go to the gym, play tennis, play pickleball. It can mean they don't want to go to social interactions where there might be get up and dance. It may feel they don't want to travel because just getting in a car for a long period of time, you're going to have to stop every 30 minutes. It can even affect sexual intimacy, and just the domestic issues of wearing pads or diapers or special bedding. All these things just create a significant change in the patient's quality of life. I want to stress to you that urgency incontinence, overactive bladder, fecal incontinence are just not normal. That is normal, not a normal part of getting older. Does it happen more as we get older? Yes, our bodies start not working as well as they did when we were 20, but it's really not normal. And this slide, although it says just part of being a woman, it's not part of being a man either. If you've got fecal and urinary incontinence, don't think you got to man up. That's not part of being a man or a woman. And for men, it's not just your prostate. And this is a very important factor that men always think that urinary troubles are prostate. But overactive bladder, either in conjunction with an enlarged prostate and prostate problems, can be problematic, but overactive bladder can exist totally on its own. And it's not something you did. It may be a condition you have. It could be neurological. It could be unknown cause. But it's not something that you did or that you can necessarily fix on your own. All right, what's the good news? There are things we can do. That's what I love about being a urologist. I get to do things that can help improve people's lives. And that's good news, especially as it relates to this. It is rare that we cannot get this better in patients. So let's talk briefly about the treatment options that come with urge incontinence, overactive bladder, fecal incontinence. This patient care pathway can work for overactive bladder or urge incontinence or fecal incontinence. And basically, the first part of this step is to consult with a physician, either your primary care doctor or us, and really discuss the symptoms and really make sure that what we're dealing with is what we think this condition probably is. Very often, whether it's fecal incontinence or urinary incontinence, we're going to have patients do a diary just to get an idea of how many times a day they go to the bathroom, whether it's urinary leakage or fecal leakage. And we may discuss some tests or treatments. I'm going to back up a little bit because my slide doesn't show, but it's very important. And if you've ever seen me in the office, you know that I talk a lot about our overactive bladder pathway. And it's what I call the 3 phases. The first phase is meeting with us, talking about what I call the things that you can do to help. That is, limit your fluids after 6 p.m. It means watching your caffeine, your spicy food, your alcohol, especially in the evening. Those things can help your bladder. Timing your bladder so that you time your bladder when you pee, so you don't wait till it's too late, so to speak. And usually after our first visit, we might decide we're going to try a couple of medications to see if we can calm the bladder down, because medications can help maybe the majority of patients if they maintain it. Unfortunately, medications don't work on everybody. They do have side effects, especially long-term. So if those things either aren't what you want to do with medications or they don't work, and I often always will try medications in a patient, we have you come back, and at that point, we will often do some testing. We're going to see what's the function of the bladder, how's the bladder working, how much can the bladder hold, is it controlling itself, can it empty itself, what's the sensation. We call that urodynamics, and it's a very important part of our evaluation of patients with urinary incontinence. We may also do a scope. I may also want to look inside the bladder, especially in men, because quite frankly, I want to see what the prostate looks like. But I also want to see what the bladder looks like in most patients to see whether there's dysfunction or whether there's some anatomical problems with the bladder. And at that point, we might talk about what I call the advanced therapies. And I'm going to share 3 of them with you as it relates to overactive bladder. So this talks a little bit, this slide talks about some of the treatments for OAB. We've talked about bladder training. We may consider pelvic floor exercises and biofeedback. We offer that in our office. It works in a certain number of patients, and you got to keep up with it. We talked about lifestyle changes. We talked about medications to calm the bladder down. So these are some of the advanced therapies. And some of you may have already had these. One of them is called percutaneous tibial nerve stimulation. Now, people are going to sit there and say, how can stimulating a nerve in my foot help my bladder? Well, it all gets back to the sacral nerve. The sacral nerve, or in particular, the 3rd sacral nerve, actually controls our bowel and our bladder. And we've learned that if we stimulate in a little area, this little nerve above the ankle called the tibial nerve, it can sometimes improve the control of the bladder by creating a neural feedback loop up the tibial nerve and out to the bladder. What I like about percutaneous tibial nerve stimulation are 2 things. Number one, there are truly 0 risk doing it. I think the downsides is you got to hang out with me for 12 weeks for 30 minutes to see if it works. And if it works and you're satisfied with that approach, you can do monthly sessions. And as long as you do the treatment, it may help your bladder. It works in about 50% of patients. And it's covered by just, honestly, every insurance I know about covers it. For some patients, that's not enough. Botox is, believe it or not just for wrinkles anymore. Botox is basically a paralytic agent. It chemodenervates, or it blocks the nerve endings and therefore weakens the bladder. And it's used obviously for wrinkles. You inject here, you can't move your brow, and you don't have wrinkles. In the bladder, it's been shown that it can actually calm the bladder down. It can actually, by partially paralyzing the bladder, help relax it. Downsides, it's got to be repeated every 6 months, 3 to 6 months. And there's about a small 5% chances that it works too well. What do I mean by that? It means you won't be able to pee. It wears off over time, and it's a small number of patients, but every patient who gets Botox has to understand that that's a possibility. But that is certainly a treatment that we offer, and I'd say it's successful in about 75 to 80% of patients. Sacral neuromodulation is what I mainly want to talk about, and I'm going to hopefully elucidate my reasons why I think this is a fantastic therapy, especially with some of the recent advances with the technology itself. So by modulating the activity of the sacral nerve, in particular the 3rd sacral nerve, we can help restore normal bowel or bladder function. Think about it as I don't want to use the word pacemaker, because we're actually sending a modulated signal versus a pacemaker to the heart sends a beat to the heart on a predetermined time. This is providing a continuous modulation to help the bladder restore its function. Works great in patients who've had previous back issues. Some of my most successful patients are patients who've had back surgery. We've done it in patients with Parkinson's disease, stroke patients, multiple sclerosis. It helps in patients who we don't know why they're leaking with overactive bladder. So the first part of this, when we talk about whether we do it, we don't just go in there and do an implant. That's not the way it's done. We have to do a trial. And the trial is the most important part of seeing if sacral nerve modulation works for you. Very few things in medicine can you try it out before you do it. You can't try out your knee replacement. You can't try out your heart valve and see if it works. One of the things I love about sacral nerve modulation is we do a test first, and we see if this therapy can help control the bladder and the bowel. The therapy that we do in the test phase is really a simple in-office procedure. It takes about 20 to 30 minutes on average. If the trial was successful, then we talk about a permanent implant, which is also an outpatient procedure. It takes me about 45 minutes, which can help for this therapy for up to 15 or 20 years. So how does Axonics work? This is just a slide that simply says it's indicated with the FDA. It's been approved for treatment for overactive bladder, urinary retention, and fecal incontinence. It is a absolutely 100% accepted therapy of the American Urologic Association. And I've been performing sacral neuromodulation for over 15 years. So how does it work? So basically, there's some abnormal communication that exists between the brain and the bladder or bowel. And this therapy helps provide a normal communication line so the brain can get back the control. It is not a bladder stimulator. I want to make that clear. This does not stimulate your bladder. It allows for the communication to exist where it once did, and somehow on the way it got fouled up. And by restoring that normal communication, you get back the control, and in many times you get back your life the way you want it. So let's talk about the test. The test works in a certain way. I'm going to describe a little bit about how I do the test. And the way I do the test is, and you're awake the whole time I do it, and it really is, not that involved. We do some local anesthesia. But let me describe briefly how we do the test. A patient comes in, we have them lie on a table, and I bring an X-ray machine in. And I'm the one that performs the procedure, by the way. No one else is doing the test but me. We use the X-rays to map out the bony structures, which tell me where I think that third sacral nerve is. And using some local anesthetic, I will numb that area on both sides, left and right, of where I think the third sacral nerve is going to be. And then I pass a small little needle into where I think that nerve is. And then I use X-rays. And then when I think I'm in the right spot, I will use a little tiny electrical current, and I'll stimulate that needle. And hopefully what the patient will feel, and I know this, I hope that you take this with some humor. Hopefully your big toe moves, your butt winks at me, and you feel a fluttering down toward your private area. And that's when I know that I'm in the third sacral nerve. I take the hollow core of the needle out, slide a little temporary flexible little wire into where that nerve foramen is. And let me be clear, I'm not putting anything into the spinal cord. We're going into the nerves outside of that area. So once those wires in, I will do that on both sides, left and right, because we're going to maybe test both sides. I pull the needles out, I tape the wires to your body, and off you go with this little stimulator. You see to the two little devices, you see the wire on the bottom, and you see the little external stimulator. It's really taped to your body, so you don't have to do anything. It's just taped there, and you're going to wear that for about 4 days. And that's our trial. And during those 4 days, you're going to keep a diary. And hopefully, we're going to see that you have decreased urgency, decreased leakage, decreased voids, and hopefully you're going to find that it's improving the quality of your life, whether it's fecal incontinence, urge incontinence, overactive bladder, or all three. The remote control is kind of neat because it allows you to change which lead and go up and down on the power, or even turn it off if needed. And once the test phase, like I said, I do the test, I send you off, you come back to the office 4 days later, and we ask, how did it work? How did it go? I'm going to go back. And if we think it's successful, that is, if you feel you get 50% improvement or not, and you're happy with the results, and you think this could be a therapy that works for you, then we talk, and only then do we talk about a permanent implant. So this is the new Axonics device, and let me tell you, it's a huge advance for a number of reasons. But number one is it's really small size. This battery reminds me of those little green thin mints I used to get at the restaurants my mom used to take me to when I was younger, those little Andes mints. Maybe speaking hopefully to the right crowd that remembers those mints. But it's a really small battery. And it's this procedure is done very simply. And hopefully this battery, which is rechargeable, which is another reason why I love this battery, hopefully it's going to be designed to last for 15 years and maybe more. A couple of things about why I like about this new technology. For many, many years, our patients could not get an MRI with the older Medtronic batteries. They just were not approved for MRI scans. So we actually ended up in many patients over the years, we'd actually remove their implant, have them get an MRI, and put the implant back in at a later date. That's not ideal. That's not an ideal situation. And this new battery and the lead are fully approved for full body MRIs. We don't have to do anything. It is completely compatible. Remote control. This is kind of fun too, because it's an easy way to turn it on and off. If you're having surgery, we might not want you to have electric cautery. Sometimes we will just turn it off. And it's a very easy thing to just turn this thing off. This battery in this thing never has to be replaced. I don't know how they do it, but it is literally a lifetime remote control. I want to talk a little about the charging system. The older batteries were non-rechargeable, and they tended not to last as long. They were also huge. They were big and bulky and very, very much visible. The way this battery charger works is you have a small little belt, and you see this little device here at the bottom of your screen, and literally you know once a month for 30 to 60 minutes, this battery will charge. So while you watch your nightly news or your favorite TV show, that thing's going to charge for a month. It is very simple to use, and I have literally had 0 patients who've not found that to be an easy thing to do. So charging is actually quite easy. All right, so does it work? All right, so this is what I said about our patients. 98%, after almost after 2 years, they're saying it's easy. 94% say it's acceptable. 98% are charging it 7 days or less frequently. When it first came out, we were actually doing every week or two, and we kind of learned you don't need to charge it that often. But charging is actually very easy, and I think it's a big improvement. And here's Donna. Donna says, she sits there, reads her book, and easy. Most importantly, does it work? You go through all this, you go through a test, you go through an implant. I would say that it's, looking at our own data, we see 90% success, that patients, when you look back 2 years, they've clinically significant. I've seen several patients in the last week who've thought this thing is really just a life-changing thing. But I get back to the idea that you get to try it out first. And that is, we see whether this treatment would be successful before we do anything permanent. Because let's face it, if it's not successful trial, and there are reasons why it's not successful, there may be other conditions that are causing these symptoms, could be prostate, could be other other conditions, and it just doesn't work. If it doesn't work, we're not going to do it. But the good news is, in the vast majority of patients, the trials are successful, and then the patients who get their implant have equal success. So here, looking at this study, 94% were satisfied, and 93% would do it again. And that's 2 years after the implant. And I think that matches up with our own data. And once again, this is what you want to see. You want to see patients, who aren't able to do their normal lives. And for my patients, it's a lot of patients who won't go to church. They're even uncomfortable going to a restaurant. They just become, their lives change. So when you get back these controls, it really can make a huge difference in quality of life. So I'm going to shift gears. So let's talk a little bit about a different type of leakage. I try to tell patients there are two main types of urinary leakage. One is urge incontinence, that uncontrollable urge to go and you can't stop it. And the other is stress incontinence, coughing, bending, laughing, lifting, sneezing. Anything that puts stress on the bladder. Also a very common condition. So normal bladder function, we'll go through this again. The bladder can hold the urine. And the bladder, when it empties, it contracts, the urethra relaxes. It's sort of a vice versa. Bladder relaxes, urethra contracts, bladder contracts, urethra relaxes. That's voiding. So stress incontinence is basically, there's too much pressure that it overpowers the sphincter. That is, the sphincter or the bladder neck cannot hold the urine in. And when that happens, with any type of exertional physical activity, some patients, it may just be standing up. But for many patients, it's really an increase in abdominal pressure, causes leakage. Once again, millions of patients have this, especially, we see this mainly in women. We see it in some men, but mainly in men who've had, prostate cancer surgery or other types of surgeries of the pelvis that can affect it. But mostly you see this in women just because of, honestly, the way the bodies are built and the stresses that women have to undergo with childbearing, et cetera. So stress incontinence may affect up to 1 in 3. And once again, any type of incontinence is going to sort of affect lifestyle, depression, self-esteem, anxiety. The leakage may cause irritation of the skin. And my goodness, the cost of pads is just, that's a multi-billion-dollar industry. Once again, here's the good news, things we can do. Pelvic floor exercises can work in some patients, mainly postpartum patients. If your uterus is gone, those pelvic muscles are probably not going to respond to exercise or what we call PT, physical therapy of the bladder. You can try it because, once again, it's got zero risk, but I am not predicting that's going to be very successful. Postpartum leakage or younger patients can work very well. So once you get beyond that, how do you fix it? In tradition, there's been 2 types of treatments: slings to support the urethra, or some type of bulking agent to basically help close the urethra so it can hold urine better. And we'll skip that slide. Sure, pelvic floor exercises, I'll briefly say, what are lifestyle changes? The more you weigh, the more mass over your pelvis and your urethra, and the more you might leak. If you're smoking, for God's sake, stop. You get a chronic cough, no sling's going to hold back the urine on some of the coughs I see some of my smoking patients have. Pelvic floor therapy, we have a therapist in our own practice, works with our patients who want to try that approach. For years, slings are sort of the gold standard. High success rates. It is surgery. And there's been many issues over the years with mesh, which makes a lot of patients uncomfortable. I personally think mesh for a sling is fine. We do not use mesh for prolapse, that is where the vagina is falling out. We do not do mesh anymore. But for urethral or urinary incontinence, stress incontinence, a sling works fine. But it is surgery, and it does have some more risks. So how do bulking agents work? Basically, they've been around for a long time. Initially, it was collagen, which is used to bulk up the lips. Then there were other agents that came And I'll be honest with you, over the years, most of the bulking agents to me were not great. They were done mainly in patients who either failed a sling or just simply weren't healthy enough to get a sling. It's a low risk. You can do it in 5 or 10 minutes, but the successes weren't great. So now we have something new. Bulkamid has been used for a number of years in Europe, but it's recently been introduced in this country, and our group was among the first in the country to do Bulkamid. What is it? Basically, it is a water-based gel that basically injecting it into the sides of the urethra can create small little pillows to close the urethra up. And by doing that, provide more resistance to the flow of urine.
Bulkamid can help provide the relief you've been longing for. The short, incision-free procedure typically takes less than 10 minutes. Involves 3 to 4 small injections of soft, water-based gel into the wall of the urethra to help prevent urine from leaking out of the bladder during day-to-day activities. It's safe, quick, and most patients can get back to your normal activities almost immediately.
So we've seen these fillers before that have used, collagen, Restylane. These things basically pump up the lips, and this is the sort of the same concept. It uses basically a gel to create these little cushions to basically close off the urine, and it's really remarkable. I was honestly a bit skeptical, but our results have been really good with this, and it literally is a 5 or 10 minute procedure, and our patients are awake when they do it. They may suck some nitrous oxide. We may use a little bit of local anesthesia to inject it, but it's really easy. And for patients who have stress incontinence, that is not urgent incontinence, but coughing, bending, lifting, sneezing, I think every patient, before they do a sling, I would recommend they try Bulkamid, because instead of having surgery and anesthesia and hospital and a foreign body in their vagina, this allows a 5 or 10 minute procedure that can basically fix the leakage. I think it's going to work in up to 85 or more % of patients. Okay. How do we do this? At this point, we're gonna end it, and I'm gonna see what kind of questions you guys have. I'd love to see you guys in the office. We're gonna make sure that we create some time for patients to come in and talk about this. My schedule often gets a little out of hand, but we're gonna create some windows for patients who want to come in and learn more about it, talk about it more. We're gonna get you in. So I hope that I gave you some good information. And we are going to follow up with you. I'll hand it back to you, Jody.
Perfect. Thank you, Dr. Capelouto, and thank you, everyone. Dr. Capelouto was excited. This is the actual battery. So just wanted to show you that. So I don't have very big hands, so I don't know what I could compare it with. A lipstick. But that's how small the battery is. Some people say
how thin it is.
And then here is your remote control. So we did have a question that says, is there an indicator to tell you when the battery needs charging? And there is. So you'll have somebody that can help you from Axonics work with a remote control that is very easy. So,
let me say a few words about this company, because I have worked with dozens and dozens of technology companies in the 30 years that I've been a physician. I've really found few companies who are so devoted to helping our patients get the most out of this technology, from beginning to end, with availability and follow-up. They come into the office to help tweak things and fine-tune it. And I think that's really important, because sometimes when you do technology, you don't get quite the support for your patients. And I'm busy. I'm moving to the next room, or I'm off in surgery, and knowing that I've got that resource with Axonics, it's really been the game changer for me, and why I've been embraced the company and the technology so much.
Thank you so much, Dr. Capelouto. And we'll start with some questions. So again, we are going to keep this pretty high level, because we can't do any diagnosing right now, but we'll start with a few questions. First one I'd just like to say is, this is awesome. Somebody had to leave early. They're interested and they will follow up. That you're the best. So I like to start off with things.
Tell them the check's in the mail. Thank you.
Yes. And also,
thanks, Mom.
So we did mention for the person who asked about, does the remote control actually help tell you when the battery? So does it tell you when the battery needs charged?
Well, it does. I mean, it's, but look, I tell my patients, you're going to charge it once a month. Just set your clock to charge this thing every 3 to 4 weeks. You don't have to worry about it. I think that the main thing about it is you don't have to worry about this charger needing a battery. But yeah, it's really intuitive. It is not hard to fit. This is easier than I can tell you my remote control on my TV. Well, maybe that's not a great example because I still can't work that blasted thing. But it's a very intuitive. We will guide you through. Do not worry about the remote control. It is remarkably easy to use.
Yeah, I was gonna say, if that helps people see, it's very simple.
Yeah, it's just a few buttons. I can do it. I'll leave it at that.
Yes. Does implant help bladder and fecal incontinence?
We have many patients who have both bladder and fecal incontinence. Understand that the third sacral nerve really controls both of those. The bowel and the bladder. So if a patient has fecal incontinence, and I'm going to say that I actually have found that for fecal incontinence, it actually works a little better than for urgent incontinence. And they both work great, but it is a remarkable treatment for fecal incontinence. And if I can get the word out for this, that it will help patients with fecal incontinence. And if you've got both, it doesn't pick one or the other, it can help both. So yes, it can help both, and it usually does.
A person is taking Detrol for overactive bladder, doesn't work.
Right.
Is there any better medication? And what medications do you recommend?
Yeah, I mean, so
or do you have to have prior?
Yeah, so Detrol is a family of what I call the anticholinergics. And they work okay, but they've got some side effects. They can cause dry mouth. I'm not sure I love using them in my older patients because of some purported potential for effects on CNS functioning. There are newer things called beta-adrenergics. So if you've never tried Myrbetriq or Gemtesa, those are the newer medications. And, we actually have samples of that. So you can come in and see us and we can try that medication as well.
If a person has had the TURP procedure, this was from male, is all hope lost for regaining bladder control? And that we can't go into ED issues, but with regaining bladder control. Absolutely.
I mean, depending on it. Now, a TURP theoretically can cause either some issues with the sphincter, and that can be fixed. But if it's overactive bladder, that is if we relieve the blockage. And for many patients, they have an obstruction and an overactive bladder. You have to relieve the blockage first. If you calm the bladder down too much and the prostate is still blocking, the patient may not be able to pee. So once you relieve the blockage, if the blockage is relieved, absolutely, there are things we can do to fix the leakage. And I would nearly guarantee a patient who has leakage after a TURP that there are things that I can do to fix that problem.
Okay, great. All right, the next one is making sure I'm getting all of them. Would it be possible to go swimming with the device? And I'm going to combine this with another one. How soon could I get back, like in the water or shower?
So I basically tell patients you can shower in 48 hours. This thing is sealed from that standpoint. But in terms of soaking it, I've got to make sure the incisions heal with any surgery, really. So I tell a patient, minimum of 4 weeks before I want this thing soaking. And we usually want to see you back to check that, to check that incision, to make sure it's sealed and healed. But yeah, eventually you're going to be swimming and riding waves and getting in the pool.
Perfect.
I don't know if I'd want the jet of the hot tub to beat on it too much, but that's probably okay too.
Yes. About how long would it take for me to see symptom relief once I have the Axonics? And go ahead and answer the Balcomid as well.
Yeah, I mean, for the Axonics, I mean, that's the trial. I mean, you're going to get improvement immediately, right? We only have a 4-day trial. So we're going to get improvement in that 4-day period, and usually in the first day. So to go and do the permanent implant is just basically reproducing the trial, but with a permanent lead, and now with the internal power supply, basically, right? So Bulkamid, for stress incontinence, also it's pretty instantaneous. I tell my patients, once you get past just the irritation and the urgency of just having something done down there, you should notice results in less than a week.
Perfect. Okay. Since you just talked about that, how long would I be out of work, or do I miss work?
Here's what I tell patients. My surgery day is either a Tuesday or a Wednesday. Let's say you come in on a Wednesday or two, either one. Take the rest of the week off. Get over the surgery. But by Monday, back to work. And, depending on your job, if your job involves you lifting 100 pounds, I'll be honest, I don't want a lot of really stressful physical activity as this pocket heals up where the battery is placed. So I tell patients for 2 to 4 weeks, I don't want a lot of strenuous work. So, but normal activities of daily living, within a week, you're back to your routine.
Which offices do you work out of?
So I work out of the Cherokee County office. I'm in Woodstock and Canton. But let me be clear, I have many of our doctors who I have, trained in this and do this beautifully. One of the great things about Georgia Urology is that we are everywhere in Metro Atlanta. And I can assure you that there is someone in every one of our areas that is doing sacral neuromodulation and Bulkamid. And we are happy to assist you. We understand that if patients are 100 miles away, they may not want to make the drive, but that's the great thing about our practice. We're in Fayetteville, we're in Brazelton, we're in Conyers, we're in Jasper. We're literally pretty much with our 28 offices in Metro Atlanta. We're going to be close by. Of course, I'm happy to see you, but we understand the challenges of the Atlanta commute and traffic.
Perfect. And then we'll just follow up with one more, because we really haven't talked about this one very much. Could I get this for urinary retention?
Yeah, no, one of the, and it depends. I will say that urinary retention, in all honesty and frankness, is not as successful. That is the bladder that is weak, the bladder that doesn't have a lot of contractility. The Axonics treatment is not as successful as it is to control an overactive bladder or an overactive bowel. It can help, and it depends on the condition and on the patient's bladder. We're happy to consult with it, but I will say it is approved. It can work, but there is a little bit more complexity to urinary retention.
Oh, here's a Bulkamid. How soon do you see results?
Yeah, usually within about a week.
Got that one. Okay, and then what about your opinion for using a medication and a device if the incontinence problem is a major one?
I can't say there aren't a few patients who got a certain amount of improvement, but a little bit of medication. But I would say, 95% of our patients who get it, they're, the medications didn't work in the first place. That's why they went on to sacral modulation or Botox or what have you. So I can't say we don't have some 1 or 2 patients who say the medicines give them that little extra. I'm not against it, but my hope is to get you off the medicines so you don't need them. And they didn't work in the first. If the medicines work, now let me be very clear. If the medicines work, you don't need third line therapy, right? Stay on your meds. If they work, great. If you don't mind the side effects and they're working great, meds are fine. It's just for the patients who the meds don't work, or the side effects are complicated and disruptive, or they don't want the long-term effects of medications. That's where we come in.
Yes, perfect. All right. Well, we appreciate your time, Dr. Capelouto. If there's anything else you can think of that nobody asked about, that you get common questions in your office?
I'm happy. If there are some questions that you want to send to me, I can certainly try and pass on some answers, through my staff if we haven't gotten to them tonight. And like I said, we're going to be reaching out to everyone who was here tonight and try and streamline the process for getting in to talk to us about it, either with me or at any of our offices. And that is my commitment, that if there's anything I want to get across you tonight, that I'm going to try and streamline this process to make it easy to get in to see us.
That concludes our presentation tonight. And I just want to thank everyone for joining us. And again, if you have any questions or you'd like to learn more about Axonics or Bulkamid, please call Dr. Capelouto, Georgia Urology, and schedule a consultation for Axonics or Bulkamid. And we appreciate everybody's time. Dr. Capelouto, thank you so much.
Thank you, Jody. Thank you, everyone, for taking the dinner hour. Go eat, everybody. Y'all have a great evening.
Yes, enjoy, and hope everybody has a great rest of the week and weekend.
Thanks so much. Bye-bye, everyone.